Well, welcome to World Patient Safety Day 2025. And today we're talking about ensuring ensuring safer care for every newborn and child. Protecting our little patients and masking pediatric pain as a safety issue. Now, we're really excited to be here today. We have a tremendous lineup of people, and I think, but more importantly, we have a tremendous lineup of people online. I think we have over 822 and counting people that have registered, and we look forward to everybody coming on board from around the world. This is a very exciting time, and really, and it's such an important topic to bring everyone together. So, welcome from everywhere, wherever you are. I think this is that's fantastic. So as we're looking at where everyone is coming from, and you can put your places in the chat, we look forward to seeing where everyone is from. We're just going to do our first just our land acknowledgement to start our day. So if we could bring that up. And we recognize and celebrate all diverse cultures and communities that are working towards healthier care and safer care and quality around the world. And so, as we look at all the people and cultures and areas, wherever you may be, we celebrate you, we recognize you, we see you in this important topic. Next slide. So, I'm one of two hosts today. I'm John McGraw. I'm an executive vice president at Accreditation Canada and HSO. Just a little bit about my background. My graduate work, master's PhD is in neuroscience, actually in neuropathic pain and neural injury. I've advised and worked on a number of therapeutics that are actually in market in pain control. And part of my role at Accreditation Canada is to guide our products and strategic offerings. My other co-host, she'll introduce herself, Sandra Young.
Good morning or good afternoon or evening, wherever you are. I'm Sandra Young. I'm the Executive Director for Standards in Education here at HSO. I'm a nurse by background. I've proudly been a nurse for the last 35 years. Half of that time was as a neonatal nurse practitioner. My PhD is in medical physiology, and I have a background in quality, safety, and leadership. And I'm really pleased to be here this morning with our esteemed panel.
Great. Next slide. Well, a little bit about our organization and our enterprise. We're not for profit, and we're really comprised of three different groups that are unified by a safer care and a healthier world for all. Health Standards Organization, as you might guess from the title, we develop standards, assessment programs, quality improvement solutions, and used for over 14,000 locations across 5 continents. Accreditation Canada, we enable organizations to meet their national global standards with innovative and customized products. And we have the Institute for Quality Management, which is really focused on proficiency testing, which helps drive the accuracy and safety of laboratory testing and diagnostic services. So thank you. Excellent. So what we are doing and what I think we're all interested in is really safer care and a healthier world. And we really want to empower people around the world to continuously improve the quality of care. Next slide. So, I think today we're going to be talking about why pain is a safety issue. When we talk about the quality of care, we're focusing today specifically on pain. And pain is not a matter of comfort. It's a fundamental safety issue with wide-ranging consequences. Uncontrolled and untreated pain can compromise psychological stability, impair wound healing, cardiovascular stress, reduced immune function, and really has been shown to increase complications, length of hospital stay, readmissions. I think the mental health aspects of persistent pain are critical safety implications. It's strongly associated with depression, anxiety, post-traumatic stress disorder, and in some cases, psychological distress can even contribute to suicidal thoughts, self-harm, um, and these are directly related to patient safety. So today we have a panel who is going to speak to many of these issues. And I'm going to introduce such an impressive group of presenters for this incredibly important topic. So first up, on the left, we have Lauren Sagan. We really welcome her, and she's a patient partner who's lived with complex regional pain syndrome for the past decade. Her journey through pediatric pain system has inspired her passion for patient inclusion and people-centered care. Lauren's worked with organizations like Sick Kids Hospital in Canada and Holland Bloorview Kids Rehabilitation Hospital in Toronto and the Canadian Pain Society. And now she helps shape health standards at HSO and Accreditation Canada. As an aside, I would like to acknowledge and congratulate Sick Kids Hospital in Toronto, Canada, for being named the world's best children's hospital last week in Newsweek and by Statistica. Obviously, their accreditation is in good standing with Accreditation Canada, and we've been a proud partner with them on their quality improvement journey, as well as many other activities. So congratulations, Sick Kids. Shout out to you. Next, we have Katie Burney. She's a clinical psychologist and associate professor at the University of Calgary, leading the Partner for Pain Research Program. She is the associate scientific director for solutions with kids in pain, and she chaired the team that developed the world's first national standard for pediatric pain management. Katie is very passionate advocate for pain-oriented research, and her work has been featured on many Canadian media outlets like CBC, CTV, and the Globe and Mail, all national media outlets in Canada. So congratulations to Katie on all those. We also have Dr. Fiona Campbell. She's a professor in anesthesiology at Pain at the University of Toronto and director of the chronic pain program at Sick Kids, where she also co-directs the Pain Center. She is a former president of the Canadian Pain Society and co-chaired Healthcare Canada's Canadian Pain Task Force and published the Action Plan for Pain in Canada and helped launch the world's first pediatric pain management standard, along with Katie. She has received honors, including the Mayday Fellowship, McMaster Distinguished Alumni Service Award, and the Canadian Pain Society's Distinguished Service Award. And finally, Melissa Sheldrick. Melissa is a trained educator and worked with families for over 20 years. After losing her son, Andrew, to a medication error, she's become a tireless advocate for patient safety. Melissa works with the Institute for Safe Medication Practices in Canada and is an active member of Patients for Patient Safety Canada. She has shared her story and expertise with audiences across Canada and around the world. So I'd like to thank all the presenters coming today, sharing their stories and giving their time up and for today's topic. Next slide. I would like to say that some of these stories will be discussions about pediatric pain experiences. And I do acknowledge that many of these stories may be emotionally difficult or challenging for some. So please step away if you need to. This will be recorded, so you won't miss this if you step away, and you can come back and join when you feel you're able to. So I just wanted to acknowledge that this can be a very challenging topic. And lastly, some housekeeping items. At the bottom of your Zoom screen, please select your language preference, either English or French. We are proud to be offering both English and French simultaneous interpretation and translation. The webinar will be made available after. And during the session, please use the chat function to share your insights. Use the Q&A function to ask a question or suggest things for future areas. So today's objective is really, we have many objectives today. I think first thing is to seek a greater understanding of pain, um, and the interventions and challenges children have, because children are not just little adults. And I think that's probably one of the great misconceptions. And, there's such a wide variety of how children experience pain, how it's caused, and how it's managed. Up to 80% of children that are hospitalized experience pain. Two-thirds of those are severe pain, and management is often suboptimal. So today, I'd like you to get a great understanding of the management of that, and differs significantly from adults. Um, and this can be much more complex in children. I just would say that their nervous systems are still developing. My work, I've spent over a decade in studying neuronal development. And kids don't start, our brain doesn't really start finishing developmental in their 20s. Some might say never, but I would say in the late 20s. And so pain that's undetected and unmanaged has a really dramatic impact on mental health, quality of life, anxiety, depression, potentially dependence on pain medications like opioids. But it's not just affecting the individual, it's a family issue, family stressors, healthcare professionals, and really has a significant cost in healthcare. Monetary, time, many different attributes. So what I'd like to get out of this today is about education, um, and think about how the majority of regulated health professionals and entry to practice education lacks instruction in pain management, let alone neonatal and pediatric care overall. So today, to wrap up, really want to increase the awareness and importance of pediatric pain as a safety issue, exploring some of the facilitators and barriers to pediatric pain management, and also to increase the awareness of the pediatric pain standard and where to obtain it. So with that, I'd like to start and welcome with Lauren to discuss pediatric pain as our patient with lived experience, because that's really patients and their experience is what's it all about. So thank you, Lauren.
Thank you so much, John, for setting the foundation for today's conversation. Good morning, good afternoon, and good evening, all, and happy World Patient Safety Day. My name is Lauren Sigay, and I am absolutely honored to be able to share some of my story with you all today. While I wear many hats, such as patient partner, specialist at Accreditation Canada and Health Standards Organization, and co-chair for the Sick Kids Pain Clinic Patient and Caregiver Advisory Committee, I am first and foremost a person with lived and living experience in the healthcare system. In March of 2015, I was 15 years old, and I had an injury that completely changed my life. What I thought would be the end of an amazing family vacation ended up being a moment of my life that I will never forget. During an innocent game of catch on the beach, I rolled my ankle and my life was forever changed. I stood up thinking I could shake it out, but in reality, it had swollen up and I was unable to put pressure on it, which to me meant it was probably strained. A week after returning home, the immense pain I felt was not going away. It was here that we started interacting with the healthcare system, trying to find answers. Was it broken? Would it heal on its own? We had no idea. So for the rest of the year, the cycle was the same. My family doctor would send me for a test, it would come back clean, and I was yet again left with no answers aside from "it'll just take time," which very quickly became my least favorite saying. Test after test and specialist after specialist, I was left with two things: no answers and even more pain. This was the hardest year of my life, being 15 with no clear direction for where I could go. Do I engage in the adult system, the pediatric system? Who would listen to me and believe that my pain was not in my head? My depression spiked, my anxiety spiked, I felt alone, and I felt incredibly lost. The problem I found with the term pediatric is that the age range was so wide, ranging from birth to 21 in some cases. Being 15, physicians would look to my parents before looking at me, asking them questions to answers I knew better than anyone. With an invisible condition, I found this difficult and incredibly frustrating as I felt my voice was never heard. Physicians assumed I was unable to make decisions for my own care, where in actual fact, I knew more about my care than anyone else. Patients are the only people who continue their care from provider to provider. And while some pediatric patients aren't as well versed in their care, I was, and I felt that exclusion from my own care plan was a detriment to my progress, and I was labeled as a child. In March of 2016, after a year of my family advocating for me, I landed at Sick Kids Hospital in Toronto, Canada. I will never forget the day I came into the pain clinic that Dr. Jennifer Stinson, Dr. Fiona Campbell, and their incredible interdisciplinary team sat me down in their pain clinic, and after 3 hours had said, "You have a pain condition called complex regional pain syndrome, and we are going to help you." For the first time in my entire journey, I had found two things that I had never had up until that point: hope and validation. A few weeks later, during one of my conversations with the physiotherapist on my new team, she had mentioned an organization called Holland Bloorview Kids Rehabilitation Hospital in Toronto, Canada as well. Holland Bloorview and Sick Kids had just introduced a program called Get Up and Go for pain management, where I would engage with a new interdisciplinary team of 9 doctors for a month-long inpatient and outpatient intensive program. Before I knew it, I was patient number 6 to enter Get Up and Go. When I came out of Bloorview, I had made strides with my pain, but my journey was long from over. Reflecting back on that year, I had realized, like many others, I had encountered many patient safety incidents within the healthcare system. The first was being undiagnosed for a year. As John mentioned earlier, untreated and undiagnosed pain is a patient safety incident, as cited by the World Health Organization. And while some may consider me lucky for have only gone a year undiagnosed, other children go even longer without a treatment or a diagnosis, which we know has impacts physically, psychologically, and for those around them. While my injury was direct to my foot, after a year of being undiagnosed, I developed a limp that affected the alignment of my back, leading to flares all the way up my right side and into my hand. Unfortunately, nerves have a funny way of working together. Had there been safeguards in place, who knows how my injury would have impacted the rest of my body and been different from the way that I know it is today. The second safety incident was around medication. I saw many specialists throughout my journey, and with each visit came a new recommendation for a different medication, not knowing what other specialists had previously prescribed. This lack of integration in the system could have led me to taking too many medications that would have interacted with one another negatively. It wasn't until I was a patient at Sick Kids that my medication was regulated by one healthcare professional, and I finally felt safe and secure taking what was prescribed to treat my pain. The education I received here was invaluable to me and my family, as we knew what the purpose of each of these new medications was and how to properly take them. And finally, the third was falling through the cracks between the pediatric and adult healthcare system. As I shared in my story, I spent most of my time bouncing between these two very different systems. And this is because while I was injured at 15, I didn't land at Sick Kids until I was 16. And typically, this is when the transition occurs between the ages of 15 and in some cases up to 18. This meant I was on the border of the two sectors. I was thrilled when I got accepted to the pain clinic at Sick Kids because I knew that for once I was going to get an answer. But at the same time, I was terrified for what came after. Was I to be treated by the adult care system, to stay in the pediatric system? Nobody really knew, including my family doctor, who ran out of options for treatment, and my family and I had more questions than answers. After my discharge from Sick Kids in Bloorview, I was back trying to transition into the adult sector where resources were slim, and I was going from an incredible team of 6 at Sick Kids to 9 at Bloorview to then me needing to advocate for my own care once again. With my continued journey of over 10 years now living with chronic pain and addressing this gap between the pediatric and adult system, it is what I am most passionate about, as this was my biggest stressor during my journey aside from my pain. I was on a path with no light at the end of the tunnel and no direction for where to go. As an advocate and educator, I've been invited to take part on several of speaking panels with many interdisciplinary professionals regarding my experiences, both negative and positive, over the years, and I now deeply value the world of patient partnership. I've dedicated my education towards being able to work with an organization that I knew could make a difference. And after graduating from my master's, being on the job hunt, I came across an article that stated Health Standards Organization and Solutions for Kids in Pain released the first pediatric pain management standard. And I knew this is where I was meant to be. While reading through this first of its kind standard addressing pediatric pain, I could only imagine the impact this would have had on my journey should it have been in place when I was in the system. I'd like to thank you for your time and listening to my story, or pieces of it at least, and I look forward to continuing this conversation. Back to you, John.
Lauren, thank you so much and explaining all that you've done. And, I think really hearing how long it took to get diagnosed, and really describing the misses, the confusion, the lack of integrated care. But also, I'd like to thank you for your willingness to speak about your personal experience. It's a gift for all of us. So thank you. Next up, we have Katie Burney. So Katie, take it away.
Wonderful. Thanks. And really nice to see everyone joining from around the world in the chat. Grateful for your time today, and grateful to HSO and Accreditation Canada for prioritizing children's pain and the topic of children's pain on World Patient Safety Day. Next slide, please. So I know this goes a little bit without saying, but I always think it's important to talk about why prioritizing children's pain matters. I think it's a very pervasive issue. So we know even from some recent updates that 1 in 5 children will deal with chronic pain. So that's pain that lasts months to years before they reach 18. And that can have a huge impact on them, as we heard from Lauren. But just to add, also critically, is our acute pains from medical procedures or otherwise that brings youth and their families to the emergency departments. And for us here in Canada, information suggests that hospitalized children will experience an average of 6 painful procedures every 24 hours. And that it can go up as high as 14 painful procedures in the neonatal intensive care unit. So it's very common, it's very pervasive. And there was an article that was published more than 10 years ago here in Canada, which talked about this medically induced pain. So pain from medical procedures in hospitalized children as a dirty little secret of healthcare. And I think that's, one of many examples of why we need to prioritize pain as a patient safety incident. Poorly managed pain has both immediate and long-term consequences. It can impact brain development, pain sensitivity, socio-emotional development in young children, but also impacts social functioning, mental health, physical functioning, school, family relationships, peer relationships, all sorts of things immediately. But it's also linked to persisting pain, mental health issues, substance use, and socioeconomic disparities into adulthood. So if we really do it well and we manage pain well in childhood or prevent it, and we're also setting people up for a greater and more successful trajectory over the course of their life. Poorly managed pain has huge direct and indirect costs, both to our healthcare systems, but also directly to families and to society at large. And one of the things that we need to understand more about, but some of the evidence that's out there suggests that poorly managed pain or dealing with unmanaged pain is highly distressful for health professionals. So when we do a good job, when we're putting into place the things that we need to do to manage pain well, it supports our healthcare workforce well-being and retention, reducing turnover and so on. And I think critically important in today's society that we also focus not just on the well-being of patients and families, but also the well-being of those who care for them when they interact in hospitals. And last but not least, managing pain is a human right. We all deserve to have our pain managed to the best extent that it can be. And we do know that marginalized groups, racialized groups, equity denied groups are more likely to experience pain and are more likely to face inequities in accessing pain care. Next slide. So as you've already heard, I had the privilege of leading development of this world's first national health standard for pediatric pain management in my role with SCIP and in close partnership with the Health Standards Organization. If you haven't looked at it yet, there'll be lots of places to gather it, and including the QR code you can see behind me. But the health standard itself is inclusive of all hospital settings that serve children from birth to 19 years less one day and their families, and that includes all areas of the hospital. So it's both what we call acute pains, short-term pains, pain from medical procedures, but also chronic pain, pain that is lasting months to years. All hospital settings, including those tertiary care, specialty children's hospitals, rehabilitation hospitals, but also smaller community regional hospitals that maybe are serving a population across the lifespan, and children and youth are just a portion of that. Next slide. There are a couple of systemic drivers you might be familiar with that have really supported and I think set this stage for the timeliness of the pediatric pain management standard. One is that for the first time, the latest edition of the WHO's International Classification of Disease identified chronic pain as its own disease for the first time in 2018. So that's chronic pain, chronic primary pain that exists in the absence of any other underlying chronic health condition. For us here in Canada, we've had a huge driver through our federal government's Canadian Pain Task Force, which led to an action plan for pain in Canada published in 2021. You might be familiar, the WHO published guidelines on the management of chronic pain in children in 2020, and also an International Lancet Child and Adolescent Health Commission that laid out 4 transformative goals for the field of pediatric pain internationally. Next slide. The health standard followed a rigorous accredited process in its development, leading to its designation as a national standard of Canada when it was published. Next slide. And the standard itself, to give you a sense of its structure, really focuses on patient-centered care, so children and families as equal members of the health team, and emphasizing principles of equity, diversity, inclusion, and accessibility. The standard has 34 criteria that provide guidance to organizational leaders or healthcare teams in delivering quality, equitable pain care. And these 6 sections, it's across 6 sections identified here. The first and the 6th really are more targeted towards organizational leaders and really emphasize the structure and systems, processes, policies that need to be available within hospital organizations to support the delivery of quality pain care. And the other sections really focus on what's needed for healthcare teams in that delivery, focusing on education across the workforce as well as for children and families themselves, focusing on what constitutes comprehensive pain assessment and reassessment, working with families to co-develop individualized pain care plans, and providing direction on multimodal pain management strategies for acute and chronic pain, including psychosocial strategies, pharmacological strategies, and physical strategies as critical for all types of pain. And it's really in the 1st and 6th section that we talk about pain as a patient safety incident. Next slide. I mentioned this standard is really based on guiding principles that pediatric pain management should be quality care and equitable care. And the standard goes on to define what those mean. Next slide. And I really wanted to emphasize, in part for our discussion today, what the health standard identifies as a patient safety incident as it relates to pain. And we heard some clear examples that Lauren shared in her experience. And the standard itself defines a patient safety incident to have occurred when a child's pain is preventable. So think about those medical procedures. Often there is a gap between many of those procedures go without any sort of pain management when we know that there are a number of evidence-based, quite simple, often at no cost strategies that can be used. When pain goes untreated, Lauren gave a great example of when pain is undiagnosed and how that can lead to more pain and more consequences and impairment for a child, and also when it's unmanaged or undermanaged. And so these are incidences where maybe some attempts have been made to address pain, but perhaps those strategies don't have any evidence to support them, or there has not been a reassessment of pain and then adaptation or introduction of new potential pain management strategies to mitigate that. Next slide. So just to give you a sense, the standard has had a lot of international interest as of yesterday. So we know that the standard's been downloaded almost 3,000 times from 78 countries around the world. So although its leadership and development here in Canada has taken place, we know it has direct relevance and application and use to guide hospitals internationally. Next slide. Again, please access it. It's available in English and in French. And then there's also an executive summary that we've developed both in English and in French as well, as a means to give a broader overview and to start that conversation further for those maybe in organizational leadership roles who need a little bit more of an introduction, because the standard itself really gets into the details of how to enact quality, equitable pediatric pain care across hospital sites. So I look forward to the rest of today's conversation and the opportunity, and just am always excited and energized to see so many of you joining and really prioritizing children's pain around the world. Thanks.
Thank you so much, Katie. I mean, that was a great description talking about the people-centered approach to developing the pediatric pain standard, where to get it. Really talking about also the, untreated and undetected pain is a safety hazard, and management is really a human right. So that's really a great perspective, and with chronic pain being its own disease. Now, let's shift to Fiona. Dr. Fiona Campbell, let's talk about, and she's going to introduce our next topic and discuss it. So thank you very much.
Thank you so much, John, and to all the speakers on the panel. And thanks to HSO and Accreditation Canada for tackling pediatric pain as your chosen World Patient Safety Day event. It's a great investment, not only for our children, but our future. My remarks today are supported by 4 patient stories to support the powerful story that Lauren has already told us, and also their artworks. So just to add to John's trigger warning, in that art allows people to explore difficult topics in different ways. So for this reason, some of the artworks or their descriptions may be disturbing to some. Next slide, please. So as a physician, via the Hippocratic Oath, I signed up to do no harm. And I will show you that pain is harmful, and therefore, by not minimizing pain, we are failing in our ethical duty to do no harm. From my work co-chairing Health Canada's Canadian Pain Task Force, which published the Action Plan for Pain in Canada, I can confidently tell you that acute and chronic pain are common, often with devastating impact on quality of life. It's undertreated, doubles the risk of suicide, and it's an expensive public health issue. Chronic pain costs the Canadian economy $40 billion in 2019, which is other work done with the task force. In my opinion, one of the most important recommendations from the Action Plan for Pain in Canada was to create pain standards, and we, in the pediatric community under Katie's incredible leadership, did just that. Also, in my opinion, one of the most important recommendations from the standard itself is to get pain addressed as an adverse event. This first drawing that I borrow from my child life colleagues, which I use with permission, you can see that pain is a highly charged emotional phenomenon, which is a high priority, we know is a high priority for families. Let's look at this picture. There's an enormous syringe relative to the size of the child who drew it. There's bright red blood and lots of negatively charged expressions. Danger, no, help, run, run, Charlie, run like the wind. The quotes on the right are from an article, old now, from the Washington Post, from a 7-year-old girl who was hospitalized for a long period of time. And you can see I've highlighted those in red that can pertain to pain. Over half the comments pertain to pain. So, is acute procedural pain, such as IV starts and blood draws, actually an adverse event? Well, an adverse event is defined as a negative result from medical treatment or intervention. And I would say that procedural, post-surgical pain and suffering fits this definition perfectly. We know that multiple painful procedures in neonates changes brain structure, reducing the amount of gray matter. Kids in elevators and hallways in the OR are often heard asking, do I need a poke? They hate it, yet it affects practically every inpatient. The fact that it may be a quick poke does not make this okay. And we know that procedural pain can lead to PTSD or post-traumatic stress disorder, needle phobia, avoidance of healthcare, vaccine hesitancy, and arguably by extension public health, as 20% of adults have vaccine hesitancy. So this is largely preventable. Causing pain is causing harm, and harm is a safety issue. We've made much progress at Sick Kids, #1 hospital in the world, over the years in getting some traction of pain as a priority, but not to the extent that it would were it considered a safety issue. By reframing pain as a safety event, we shift accountability from individuals to systems with adverse event reporting, root cause analyses, leading to systemic improvements. And we know from the pain standard and other guidelines that we have plenty of opportunity and resources to guide change. Next slide, please. So when I talk about pain, we can think about acute pain, which can be procedural pain that I've just spoken about, or the ultimate in procedural pain is pain after surgery. This is acute pain. I'm going to talk about chronic pain momentarily. The X-ray on the left shows a patient with scoliosis before and after surgical correction. This teen will have had a deep incision down their back from top to tail, installation of screws and rods fixed into place. This is a big deal. It's associated with severe postoperative pain and provides a significant risk of developing chronic pain. When I was president of the Canadian Pain Society, I created the Art Awards, and this is a painting from the 2025 competition submitted by a 16-year-old demonstrating highly charged images of pain. Arabella says, she's 16, this artwork depicts my chronic pain and shows the tension between being myself and hiding behind my mask, which you can see has a smile on it, when I feel I can't meet societal expectations. But in addition to the mask, you can see the stigmatizing comments. I'm going to come on to stigma in a minute. You're a liability, you're a burden, you're a liar, you're a drama queen. This kind of language is not at all helpful. We know that the majority of patients in hospital experience pain, over 2/3 in the significant range. It's undertreated. We've heard about the sequelae, unplanned readmissions to hospital, and we also know that severe acute pain after surgery has a strong association with the development of chronic pain, and we know that about 40% of kids with 30 to 40% of kids with bone-cutting surgery will develop chronic pain. Why is it that pain is undertreated and overlooked, even in children? Well, it's subjective, invisible. There's no definitive diagnostic test. There's inadequate pain education across health providers. Vets get 5 times the dedicated pain education than do medical students. And pain also, people don't really think about this, I don't think, but pain is typically a byproduct of why people come to hospital. So it's not necessarily anyone's priority, including the most responsible provider, except perhaps for the children and families themselves. Next slide, please. So this is an incredible painting by Hertz Nazer, who's not a child. He's an artist, an adult author, an advocate who lives with sickle cell disease, who represents the pain of sickle cell disease. This is a genetic condition and the most common painful condition worldwide. It leads to misshapen red blood cells that sickle, and you can see those in his painting, and they have a tendency to block or clog arteries and block blood flow to tissues, leading to immense pain known as vaso-occlusive crises. Pain can be acute or chronic in association with medical diseases, such as sickle cell disease, rheumatoid arthritis, cancer. These are somewhat different from painful procedures and surgeries in that we as healthcare professionals do not cause the pain associated with medical diseases. And while we can't necessarily prevent this pain from occurring, there are ways to mitigate it, which we should do per the pain standard for the reasons already given. Next slide, please. This is a final painting that I will show today. It's by Chloe Fleischer, who won the CPS Art Award in 2022. She's a 13-year-old girl who describes her journey living with chronic pain for more than 5 years. I drew this image to express how I sometimes feel when I'm in pain, like I'm drowning or submerged. The pain consumes my whole body. I'm helpless, and there's nothing I can do to stop the suffering or to help myself. So chronic pain can be secondary to other diseases, or it can be a disease in its own right due to abnormal pain processing, like crossed wires. Acute pain is maybe like a hardware problem, and chronic pain more like a computer software problem, messaging in the body. Chronic pain may not necessarily be preventable, but the pain standard accounts for this with an imperative to ensure that patients with any pain are managed appropriately. And thank you again, Lauren, for sharing your powerful story. Just think, had her initial pain been addressed early in her trajectory, it may not have become chronic. Significant acute pain in kids is associated with the development of chronic pain. We also know that 2/3 of kids living with chronic pain become adults with chronic pain, and youth living with chronic pain are at risk of opioid use disorder as an adult. By treating pain in youth, we can reduce the burdens of pain and addiction in adults, improving the health of Canadians. We know that chronic pain affects 1 in 5 kids living in Canada, disproportionately affecting equity-deserving populations. It's common, it's disabling, with major effects on quality of life associated with mental health. We've heard it doubles the risk of suicide. Importantly, it's associated with significant stigma, leading to patients being disbelieved even by health professionals. This became very clear through my work as co-director of the task force. So why is there this stigma? Pain is invisible and subjective. There's a lack of a diagnostic test. There are myths and misconceptions. We all have pain. Yes, we need acute pain to protect our bodies from harm. It's part of survival of the species. We all have pain, so why don't you just suck it up? People with chronic pain smile, look normal, so pain can't be that bad. If you take a pain medication, you must be weak, or if you take opioids, you must be an addict. Next slide, please. So I just this is my call to action, whether it be acute procedural pain that we saw in the image on the left, or post-surgical pain, the second from the left, or the pain associated with diseases, or chronic pain just occurring as part of a disorder in the nervous system. My number one priority is to do no harm. Secondly, we should reframe pain as an adverse event, as a minimal pain, and have minimal pain as a standard of care. This shifts accountability from individuals to systems, leads to adverse event reporting, root cause analyses, and systemic improvements. The pain standard and other guidelines exist to guide this change. A safer health system is one where unnecessary pain is no longer tolerated. I recognize that culture change is hard, but this is no excuse not to move in this direction. Thank you. And back to you, John.
Well, thank you very much for that call to action and your clinical perspective on pain and as a patient safety issue. Your the role in the Canadian Pain Task Force or National Action Plan and the importance of standards is wonderful. But what was really amazing is to see the artwork and to explore children's experiences of pain through that with lived experience. I think that's incredibly powerful to help children express what they're feeling and also to help others interpret what they're going through is just one way. And I think that's so wonderful to bring that to everybody today. And I appreciate the acknowledgement that might be challenging for people to see, but I think it's as adults on the call, I think it's so important to see different ways of how children express themselves in this debilitating um, condition. So thank you. Melissa, over to you to talk about your topic and close out our speaker panel.
Thanks so much, John. And thank you to HSO and Accreditation Canada for inviting me to be here on this esteemed panel. Such an honor to be able to share some information about my own personal experience and also some general medication safety for our littlest ones. As you heard earlier, I come into this landscape of medication safety and patient safety after the loss of my son Andrew to preventable medication errors. Andrew did not suffer from physical pain, but he did struggle with a different disorder. Next slide. Thanks. Andrew was a very active little boy. He loved soccer or football, depending on where you are calling in from today. He loved his friends. Most of all, he loved to swim, and being outside was always his first choice. We lost Andrew to a series of errors made during the dispensing of his medication in 2016. He was taking a daily dose of tryptophan to help regulate his sleep cycles as he had been diagnosed with parasomnia. This is a sleep disorder, and for Andrew, he went into his REM sleep cycle twice as quickly as normal. After the discussion with the doctor, I was comfortable with this prescription of tryptophan because I had been concerned about potential side effects from stronger medications. But a conversation with the doctor really helped me understand the risks and benefits of this treatment plan. Because Andrew was quite small and the tryptophan tablets were quite big, and we were not able to really crush them well, I asked if there was a liquid form of tryptophan. The doctor advised me that there was not, but said that I could take the prescription to a compounding pharmacy to see if they could make it into a liquid. They did, and we refilled it every 2 weeks for 18 months until one Saturday in March of 2016. I gave Andrew his dose before he went to bed, and he didn't wake in the morning. For 4.5 months, we didn't know what happened, and then we were told that the medication bottle that had been sent for testing contained no tryptophan at all, only baclofen mixed in the same concentration as his tryptophan, equivalent to 3 times the lethal dose for an adult. This was a 10-fold overdose for a child of his size. As I began to process the fact that medication errors happen and that they are largely preventable, I turned to advocating for continuous quality improvement programs, including mandatory reporting and learning in community pharmacies across the country, beginning in my home province of Ontario. This began my transition away from teaching in public school to learning about medication and patient safety, and now my teaching involves opportunities just like this. Next slide, please. As I mentioned, we were directed to a compounding pharmacy to have Andrew's medication made into a formulation that worked for us. This is a common practice here in Canada because there is a lack of commercially available child-appropriate formulations. Parents sometimes have no choice but to take the prescription to a specialty pharmacy, where pharmacists must manually prepare medications to suit a child's needs. While necessary, this process introduces risks such as dosing errors or even contamination. And again, we have to remember that our kids are not little adults. Their bodies process medications differently, and even small errors can have serious consequences. Their weight, their body chemistry, and developmental stage can all be variables in how medication affects them. And so great care must be taken for all medications given, but especially compounded ones. Some good news is that Health Canada has published a national priority list of pediatric drugs. This is a list of medicinal ingredients that a pediatric external reference group has identified to address areas of unmet pediatric needs in Canada. The medicinal ingredients on the draft list fall under one of the following categories: that they're not currently available in Canada, that they're not available in a child-friendly format, and or they are not indicated for use in children. There has been some strong advocacy work done across the country by parents, by safety organizations, by pediatric health providers, and others to get access to commercially manufactured products for children that already exist in other countries. Work is ongoing to advocate for this access, which could eventually reduce the need for compounding and the risks that it carries. Next slide, please. There are medications that people can be prescribed off-label. Off-label means that the use of the medication is different than what Health Canada has approved to be marketed in Canada. For example, a prescriber may offer this option if there is research that shows the benefits of a particular medication for a condition that outweighs the risks. One example that's featured here in this newsletter is of a blood pressure medication for an infant. The caregiver was unsure of the prescription because they knew it wasn't approved for children, but they engaged in a conversation with their prescriber and they asked questions to better understand the risks and benefits. Once the caregiver received the information, they were able to make an informed decision. This was very reflective of my own experience. This concept is important for parents and caregivers to consider when making decisions about their children's prescriptions. For children who contend with pain, whether it's acute, whether it's chronic, the decisions about appropriate medications should also complement other strategies that children and parents may be using to help with pain. Next slide, please. We know that opioids are a high-risk medication for all populations, but especially for children and youth. Whether they are prescribed for pain management, for acute reasons, or chronic conditions, opioids carry risks of overdose, dependency, and adverse reactions. For children and teens who are faced with pain, they may use opioids under the supervision of their health team and caregivers, and this may give them some relief. The risks remain prevalent, and that means that the carers of the child must have safety strategies in place. As you can imagine, pediatric opioid safety requires careful prescribing, clear communication between families, prescribers, and pharmacy teams. It also requires secure storage in the home. Parachute Canada reports that medications are the leading cause of poisoning in children. For families who need these strong pain medications and any medications, they must keep them up and away, out of sight, and potentially under a locked system. It's also wise to ask a pharmacist or prescriber if naloxone is safe for their child, and if so, keeping it accessible in the home is important in the event of an overdose of an opioid. Next slide, please. These 5 questions were developed with a team of people from across the country, including folks on this webinar. It was co-designed by safety organizations, patients and families, pediatric healthcare providers, and others. One of the goals of this tool you see here on the left is to get kids comfortable about asking questions about their medications. We heard directly from Lauren about the importance of her being addressed about her own pain and her care. Teaching them as early as 6 or 7 years old that having a conversation about their medications and their health in general will help spark their health literacy and help it to grow over time so that when they're adults, they can speak up about their care and be part of their own safety journey. There are some safety tips there for them to remember as well. Starting simple and starting young will help empower them with a tool belt of skills. Our kids who face pain management struggles and strategies will be better equipped if they have the information that they need. On the right, you see a newsletter. Oh, sorry, wrong slide. Just to finish up, I wanted to reinforce some 3 key messages. The safety needs of our kids must be understood and addressed differently than those of adults. They have very specific needs, and the same condition in an adult and a child can present very differently. Medication needs must be thoughtfully discussed with the whole child in mind. Medication risks are a significant safety issue for children and youth, and we must be very diligent throughout the whole medication process, from prescribing to dispensing to administration. Children span a wide developmental range, from infants to teens, and our medication safety strategies must reflect that diversity and their growth and development. Thank you so much for your attention and for your commitment to improving medication safety for our youngest patients.
Thank you very much, Melissa, for sharing your challenging story with everybody. And again, patient and family stories are so important and a gift to all of us to improve the lives of others. And we really appreciate you and Lauren's courage to be here and then share your experiences with everybody on this webinar today. It is very much appreciated, and it's not, it's very well recognized. So thank you. Also, thank you for reinforcing kids are not little adults and safety needs really need to be understood, and medication risks are a major safety issue for everybody, but in particular children, given what you've described. And I think that's such an important issue because medication access we just think about for adults, but it's even more challenging for children. So thank you very much. So now I turn it over to my co-moderator, Sandra, and she's going to summarize our information and relate it back to some of the core things that what we do. So Sandra?
Thanks so much, John. It was a pleasure listening to all of our speakers and such powerful messages, highlighting the physical, psychological, and pharmacological complexities of pediatric pain. Lauren's comment really resonated with me. It will just take time. Yet we know that untreated and undiagnosed pain is a safety issue. And listening to even our youngest voices of those who know their pain best helps us to reduce the risk of harm. We also heard about the risk of harm when transitioning from pediatric to adult sector, and remembering that unmanaged pain is highly distressing for healthcare providers as well. So emphasizing that preventable pediatric pain is a patient safety incident to be managed, and shifting our focus from people to processes and systems is what HSO is all about, driving quality improvement and patient safety. So I welcome our panelists to join me to a conversation, and we'll open it up with Katie, and looking to you, Katie, as lead for how proud we are of our pediatric pain standard. And if you can speak to some of the impact that you've witnessed and that Skip has certainly enabled with the introduction of the publication of the pediatric pain standard.
Yeah, it's such a big question, Sandra, and you warned me you were going to ask this. So I've been thinking about it, and I think it's phenomenal that this is a space we've had a chance to lead, kind of in our pediatric space, and even within the child health space. So, really putting on the map, I think, why children matter and also why pain matters. And there's so many tangible actions, I think, that the health standard guides. And we've chatted about this before. I think a real benefit of health standards over something like clinical practice guidelines is that they also address the organizational systems, structures, processes that make it possible for health professionals and healthcare teams to engage in the quality care they want to. I've worked in the pediatric pain space, probably for the last 15 years or so. And oftentimes we are the ones kind of advocating and trying to get people to care about children's pain. I think when we saw this standard published, we saw a real shift. I was often in places where I said, "Have you heard about this?" And they said, "Yes, we already know." And so, that for me has been a huge impact to see people looking for information as opposed to us kind of trying to push that out. But ultimately, I hope, the greatest impact is the culture shift that Fiona mentioned. I continuously hear how pain in kids might be a niche topic. And, we're obviously biased. Some of us on this call, as this being the space that we specialize in. But pain is ubiquitous to our health interactions, whether it's something that's part of routine care for generally healthy people like vaccinations or, for diagnostic testing, or whether it's becomes a part of daily life, like Lauren mentioned. But I hope that this really starts to shift how we talk about it, because we have solutions. I mean, this is the beautiful thing about this space. We're not just trying to raise profile of a problem that's going kind of unaddressed, but alongside the solutions that are available that we know can work to address it. And so I hope that, that doesn't always happen, right? Oftentimes we're just raising profiles about a problem. My hope is that the ultimate impact is a culture shift and an attitude shift, that this is something we can change, we can make better. We can reduce harm that is a direct consequence of healthcare, which is there to make things better, with the solutions to do that. So, yeah.
Thank you so much, Katie. And Skip has been so powerful in the implementation and the uptake of the standard. And we're committed to our ongoing work with Skip to be able to bring those solutions to life. So thank you so much for that, Katie. Appreciate it so much. Just turning to Fiona. Fiona, if we asked you about, when we're taking this systems view and moving beyond the people, but really looking at where we can make a change in the systems and the processes. If we could ask you about one change that you might make in the system to help us to better address chronic pediatric pain, what do you think that might be?
Well, limiting it to one is really kind of unfair. How about I have two?
You can have
I'm
as
gonna do two
Okay.
anyway. So I think we firstly need a structural and systems level support for pain management, which incidentally would be addressed by implementing the pain management standard. Right now, pediatric pain care is siloed, under-resourced, and so a key change would be to embed evidence-based practices into every level of care. This means ensuring dedicated funding, staffing, time for pain services, and importantly, as I hope I have persuaded you, making pain outcomes a tracked safety metric across children's healthcare organizations. So really the structural system level support, and that was really the thrust of my presentation, that pain be considered a safety event, but really this can't happen in the absence of training and cultural change among providers. So many of us receive very little formal training in pain. I mentioned the quote that vets get 5 times more training than medical students. So all of this fuels under recognition and under treatment. We need mandatory education in pain neuroscience and pain management across all health professions. And importantly, just going back to the issue of culture. Culture change is hard, but we do need this shift in culture so that children's pain is taken seriously, just really emphasizing Katie's point there, and addressed proactively and not dismissed as something secondary or something they'll outgrow. So yeah, structural system level support, also with a training and cultural change to support that. Thank you.
Excellent. So really the recognition and the intervention, the reporting, the learning, the improving, to have the whole system connected, addressing pediatric pain, and to have those structural and system processes in place. Thank you so much, Fiona.
My
I think
pleasure.
when we talk about the systems and the integration of the systems, Lauren, this is something that is near and dear to both of our hearts and certainly your lived experience. But I wonder if you can expand a little bit more about those transitions from the pediatric sector to the adult sector. And we know in so many ways that creates risk for harm, risk for delays, risk for fragmentation. And maybe some of your lived experience and certainly your being our colleague here at HSO, some of the guidance you would give us about bridging that gap and creating greater integration across the system.
Yes, thank you so much. So I think one of the biggest pieces is that there is not as many resources that I found in my experience in the adult care system as there is in the pediatric system. As I've said, I was beyond grateful to have such an incredible team at Sick Kids and have so much support where anytime I had a question relating to my pain, I had a dedicated person of who I could connect to. Family doctors, while they are so well trained, when it gets into a specialized condition, it's really difficult to get very specific answers from them. So when you go from such a supported system in the pediatric system to the adult care system where you're kind of left alone to navigate it on your own, that's where it becomes very difficult. It's the, okay, well, who do I go to now? Where can I go and talk to now? So that's one of the problems that I found. And then trying to understand and look at the individual as a person as a whole. Being 15, I was in high school, or at least trying to navigate through high school and then trying to
Right.
navigate to university. So, as we talk about a lot at our organization, looking at people-centered care, looking at the individual as more than just a diagnosis, World Health Organization also understands the impact of people-centered care as well with their definition, and really understand where we can add more resources to support patients and their loved ones through that transition is where I think we need to look at the most, and supporting them through not only dealing with their pain conditions, but also dealing with the transition that is a major transition in their life as well.
So would you say having a central contact, a central coordinator, a known person that you can go back to and contact to help with the coordination and comprehensive management of your care?
Absolutely. It was really quite difficult in my experience to being able to have such a tight-knit team and then trying to say, okay, I go to patient A for this and patient B for this and patient C for this, and A, B, and C are not talking to each other about what's going on and when. So trying to get that integration in the community is very difficult when it's already been so safely secure and connected within the pediatric system.
And I know thanks so much, Lauren. I know there was so much support from your family and your mom throughout your journey. And so if I turn to Melissa and I think about parents and we know that pharmacological management is a big piece of pain management, or can be for pediatric patients. I wonder if you can give us some guidance, Melissa. You gave us some great tips in your slides, which were really concrete and applicable and readily usable. If you could give some guidance to healthcare providers and healthcare leaders on how we can better enable parents in the safe management of not only pediatric pain, but pediatric medication management.
Yeah, absolutely. And there's often, multiple prescriptions that go along with, pain management. And so we have to be really careful. And one of the trickiest things is for parents to be able to navigate these systems that are complex, right? They're not easy to navigate. And medications, as I spoke about and as we've heard today, are so risky for kids. Our kids are very vulnerable at this age, and so we have to put these systems-based solutions in place in order to protect parents and kids and providers too. And so a couple of things that I thought about was that prescriptions are not always clear. They're not always shared what they are for, what the specific indication is. Medications come in different concentrations and there's different instructions. So really ensuring that parents understand what the medication is for, what the dose is, how to give it, engaging in like a teach back method to ensure that they've understood is really important, because this is a risky process, whether the prescription is compounded or not. And, as a parent, when your child is in pain, that's already so much stress on yourself. And so to be able to manage all that information is increasingly challenging. And so, one really important thing that providers can help parents do is to keep an accurate and up-to-date medication list that they can take with them to whichever provider. There could be, multiple providers that the child has to see. And it's really important that all of those providers have that list so that they can see what's working. They can adjust things as needed. But having that up-to-date list is really key, and providers play a key role in being able to support parents with that. And, sort of the umbrella of all of this is about communication in all its forms. And sometimes pictures and infographics are better than written words. And so having that available where possible for parents to hang on to print out, to keep on their phone, whatever that might be, could be really important too. And I think the final important piece for me to talk about is the importance in engaging with parents and kids to design solutions. What is it that their lived experience is informing us about? That's really an incredibly unique perspective. And they have walked this journey and they really know the truth of what's happening. So connect with your families, learn from them, and get them to help you design solutions and find what works for improvement. And when we improve quality, we improve safety, and we look after our kids and our families.
So well said, Melissa. The knowledge of the pediatric patient, the knowledge of the parents. There's so much to be gleaned from that experience. If we watch and if we listen and if we truly partner, I think there's so much to be said about making that safe space and creating that safe space so that people can come forward and can ask that question, especially when we think about compounding medications, low volume, high risk, very individualized. And that's where we start to lose those checks and balances of what gets automated, what gets mass produced and standardized, and where we really need to be optimizing human factors. And so all the more reason to say, to create that space for a parent to say, I'm not sure about that, or that seems different, or I don't remember that. And so I think your how you've relayed your experience is just so powerful for all of us to remember that we're in partnership together in the care of our littlest patients. So thank you so much for your perspectives. It's really, really important. I'm just going to turn to the panel and see if anyone has any last words that they want to make sure that we relay. Oh, Fiona's got her hand up. Go ahead, Fiona.
It's not really a last word. There's a question actually in the Q&A that hasn't been addressed, and I just it's easier for me to say. So the question is how to educate senior hospital staff about pain management in pediatrics of third world countries that don't have accreditation. So, the accreditation is a really good leverage to have, but it's not the only thing that you have. So and we haven't always had pain included in accreditation standards. So I just want to respond by saying, first of all, is to try and make it a priority. Raise awareness in your hospital. That's not just a top down at the executive level, it's also bottom up. So it's not only senior hospital staff, but you also need to educate interprofessionals across the organization so everyone is becoming aware. And then you start getting a bit of a culture shift. A couple of other things that you can do is to benchmark how things are right now. So do little pilots. Is pain being assessed in the organization? Are there pain scores in the moderate to severe range? Are there patient satisfaction surveys being done in your organizations that include pain as an issue? And so all of those things you can do to just bring to the attention of people in the executive that this is something that patients care about. And you can also take the documents, international documents, like the WHO guideline, the Lancet Commission is particularly powerful. And then in Canada, even though ours, the National Action Plan and the PEDS pain management standard are unique to Canada, their messages are universally applicable. So I think with international information and resources, with patient surveys and benchmarking, and trying to leverage this stuff to make it a priority in the organization, you have to start somewhere. It's hard, and that's kind of been my journey, actually. So thank you for asking that question.
It's so well articulated, Fiona. Starting with the evidence, starting small, building from grassroots up, and utilizing the stories and the experiences of patients and families as well. Thank you so much. Any other last words? Oh, Lauren, I saw you come off mute.
Yes, I just have a quick comment that I wanted to add. We've all been saying the importance of listening to the individuals receiving care, whether that's the kids or the family members. And I just want to put a plug for an incredible paper that we look at quite often within our organization called the 6 Types of Experiential Knowledge That Patients Develop Through the Healthcare Journey by Vincent Dumais. And his colleagues out of the CEPPP here located in Montreal, Canada. This really outlines the types of knowledge that we understand throughout the journey and that patients develop throughout their journey, whether that's navigational knowledge, knowing who to turn to, relational knowledge, and etc. So I would really highly recommend looking at that because it really puts the literature to what we as patients know as the types of knowledge that we carry.
Thanks so much, Lauren. May I ask you to put Vincent's paper in the chat for others to access as well? Thanks so much.
Of course.
I'm going to turn it back to you, John, to close us out.
Well, that's thank you very much for those concluding comments, and we're drawing to the end of our webinar, and I would like to leave everybody with a challenge. We heard a few direct actions you could take, but I really encourage everybody to just to follow up and to say to prioritize pain management. Ensure that pain is assessed and managed and an integral part of your safety protocols with children. Whether you're a healthcare professional, caregiver, patient, someone dedicated to global health, all of the above, combinations thereof, we all have a role to play. So I really encourage you to do that. And as your one thing to do is to really prioritize that. Today, I also, as part of our continuous quality improvement, like every organization, we welcome feedback on today's webinar. There's going to be a feedback evaluation mechanism, and I think that's going to be launched. And hopefully you found today's webinar very insightful, very impactful, gave you some next steps, made you think about things in a different way. If you did, I really encourage you. Our next event is October 15th in honor of World Standards Day, where we'll be talking about designing healthcare for resiliency and standards for climate change. And actually, medication management and prescribing and de-prescribing are all part of that. It's all integrated. So this is not a topic that's just over here. It's a topic that's related directly to patient care and all patients at all stages and all stages. So thank you very much for your time and your attention. And I thank our panelists for taking time out of their day to share their experiences, knowledge with over, I think, 800 people from around the world. I really thank everybody for their time. So go download that standard, read it, and enjoy the rest of your day, and prioritize pain management as my closing thought. Thank you.